Hello, I'm Nancy Brundage from VPS. Welcome to our third session of the VPS Research Spotlight Series. If you haven't joined us before, this is a quarterly presentation of recently published research using the VPS data. I'd like to take this opportunity to let you know that if you're from a VPS participating unit and you're interested in doing a research project with the VPS comparative data set, you're welcome to apply. We have a very active research committee of over 30 intensivists from around the country to review proposals for VPS. You're welcome to contact us for more information. Today, we'll hear from Dr. Ryan DeSanti on his recent work on the utilization of critical care resources in pediatric neurocritical care patients. If questions arise during the presentation, please go ahead and post them anytime in the Q&A section, and we'll take those questions at the end of the presentation. Dr. DeSanti attended medical school at Midwestern University, Chicago College of Osteopathic Medicine, and did his pediatric residency at Cooper University Hospital in Camden, New Jersey, followed by his fellowship in pediatric critical care medicine at the University of Wisconsin-Madison. He is board certified both in general pediatrics and pediatric critical care medicine. Dr. DeSanti is currently an assistant professor of pediatrics at St. Christopher's Hospital for Children in Philadelphia. Without further delay, Dr. DeSanti, would you please share your work with us?
Thank you for having me so much. I'm so excited to share the research project I was able to do concerning utilization of critical care resources in neurocritical care patients within the PICU. And so we know that neurologic diseases represent a large burden within the pediatric intensive care unit. They typically represent 10 to 20% of PICU admissions. And we know that children with neurologic diseases typically require significant hospital resources, including things like mechanical ventilation, spinal fluid diversion, and rehabilitation, which leads to a higher cost of hospitalization and longer duration of both hospital and PICU stay. As such, there has been increasing interest in providing specialized care to these children in the form of neurocritical care, but research identifying best practices remains sparse. There are a few studies evaluating critical care practices in children with neurocritical care diseases. As such, the goal of our study was to describe patient characteristics and utilization of resources among patients with neurologic diseases in a large cohort. And for this study, we decided to use the VPS database. The specific aims of our study included defining the prevalence of primary neurologic diagnoses, the admission characteristics, and discharge characteristics, as well as describing the utilization of PICU and neurocritical care specific resources, and determining the frequency of physiologic derangements that can be associated with secondary neurologic injury among the neurocritical care module, which was built within VPS. And so we evaluated all patients who were admitted to VPS participating hospitals during 2016. This included 123 hospitals and 128,688 patients. We chose 2016 as the study year because this was the year that the neurocritical care module was piloted within VPS. The neurocritical care module was a voluntary research module that was built within VPS and designed to open when patients met one of 65 predefined inclusion diagnoses. When the module opened, data entrants were prompted to enter pre-hospital medication and fluids, which were administered to patients, emergency department medications, fluid and blood product administration, as well as fluid and blood product administration in the PICU. The module also collected pathophysiologic variables which can be associated with neurologic injury. This included things like presence of hypoxia, seizures, hypo or hypothermia, hypo or hypoglycemia, as well as intracranial hypertension and low cerebral perfusion pressures. We grouped all 128,000 patients into either a general PICU cohort or neurocritical care cohort using institution-supplied primary patient diagnosis. The primary diagnosis in VPS is considered to be the principal reason for the patient's admission to the PICU, and which is the reason we chose it as the deciding factor to cohort the patients. We group neurocritical care diagnoses into seizure disorders, infectious neurologic diseases, traumatic brain injury, ischemic encephalopathies, oncologic diseases, stroke and vascular diseases, inflammatory and neuromuscular disorders, neurosurgical disorders, spinal cord anomalies, congenital brain malformations, and other neurologic disorders. We classified general critical care resources as mechanical ventilation, including both invasive and non-invasive ventilation, new gastrostomy tube or jejunostomy tube placement, utilization of a Foley catheter, utilization of arterial line, central line, PICC line, extracorporeal therapies, including renal replacement therapy, plasmapheresis, and ECMO, as well as CPR. We classified neurocritical care resources as EEG and seizure monitoring, imaging, including CT and MRI, ICP monitoring, neurosurgical interventions, including CSF sampling or diversion, intrathecal device placement, and operating room or interventional radiology procedures, and neuroprotective therapies, including hypothermia and barbiturate infusions. Of the 128,688 patients who were entered in VPS, 24.3% had a primary neurologic admission diagnosis as defined by these categories, while 75.7% had a non-neurologic primary admission diagnosis. The top admission diagnoses of all patients included respiratory diseases at around 31%, neurologic diseases at around 24%, and cardiovascular diseases at around 11%. Of the 31,000 patients with a primary neurologic diagnosis, the top diagnoses of these patients included seizure disorders at 24%, traumatic injuries at 16%, neurosurgical disorders at 14%, and spinal cord anomalies at 11%. In evaluating the admission and discharge characteristics of the two cohorts, we found that the neurocritical care cohort tended to be older, ranging from 6 to 18 years of age, represented more scheduled admissions, and were more commonly admitted through the OR or PACU. The neurocritical care cohort also had longer standardized length of stay and higher standardized mortality ratios. For resource utilization, we found that the neurocritical care cohort more commonly had Foley catheter placement, arterial line placement, and less commonly had central venous lines placed. We also found that they more commonly used EEG and seizure monitoring, more commonly had CT scans, MRI, and ICP monitoring, as well as neurosurgical interventions. One of the things I would like to point out is that most of the comparisons which we did evaluate between the two cohorts reached statistical significance given the high volume of patients that we evaluated. We did complete a secondary analysis of only unscheduled patient admissions. So this is removing patients whose admission to the PICU was pre-planned. And in this cohort, we found that the neurocritical care cohort still tended towards the higher end of the age range as compared to the general PICU cohort, although slightly younger than in all patients. The neurocritical care cohort still was more commonly emitted through the OR or PACU, but more commonly emitted through the emergency department as compared to the general PICU cohort and all patients overall. The neurocritical care cohort still had higher mortality, as well as higher utilization of arterial lines, lower utilization of central lines, higher utilization of Foley catheters, and also more commonly used endotracheal tubes and endotracheal intubation, as well as neurocritical care resources. In looking at patients who had diagnoses that made them eligible for the neurocritical care cohort module, there were 38,000 patients entered with an eligible diagnosis in 2016. Of these, about 33,000 were admitted at a non-participating institution, which left 5,716 patients with an eligible diagnosis at a participating institution. 40% of these patients did not have any data entered into the module, which left 1,715 patients eligible for the module who were entered. And of these eligible and entered patients, 448 patients were manually excluded by the data entrant. This left 1,267 patients for analysis. The top admission diagnoses of these patients included seizures, traumatic brain injuries, neuro-oncologic diseases, and stroke and vascular diseases. This cohort, the neurocritical care module cohort, was broken down into patients with neurotrauma and non-trauma. And we did this because some of the collected variables, including hypo and hypernatremia, as well as hyperglycemia and hypoglycemia, were only collected for neurotrauma patients. Among all module patients, we found a relatively high incidence of hypoxia, defined as saturation less than 90%, a high incidence of hypothermia, as defined by a temperature less than 36%, including a high incidence of severe hypothermia, which we define as less than 32%. Hyperthermia was also relatively common, occurring in 37% of patients. Among patients with neurotrauma, dysnatremia was also very common, occurring or having hyponatremia is defined by a sodium less than 135, occurring in 15% of patients, and severe hypernatremia as defined by a sodium greater than 156, occurring in 6% of the patients. Hypoglycemia was also fairly common, occurring in 15% of the patients. And utilization of ICP monitors was fairly uncommon, occurring in 3.2% of the total module patients and 6.9% of neurotrauma patients. We included in our study a large number of previously unconsidered neurologic patients who received care in the PICU. These include scheduled admissions, postoperative patients, congenital brain and spinal cord malformations, and many other less commonly classified neurologic diseases who require PICU care, including patients with syncope, headache, migraines, pseudotumor cerebri, and autonomic disorders. And among a convenient sample of neurocritical care module participating institutions, we identified a high frequency of pathophysiologic events that can be associated with secondary neurologic injury. Of course, there are many study limitations for this project, the most prominent of which is that we group patients by their primary admission diagnosis. And so it's possible that there were acute neurologic diagnoses that patients had on admission, but were not included in the module. We also did not include events that occurred during the hospitalization as neurocritical care patients. It's also possible that documentation bias occurred, particularly in entry of optional data fields within the VPS database. Our data also came from a single study year. So of course, it's possible that there's year-to-year variation in data. And finally, we had a low proportion of patients who were eligible for the module included in the module, of course, which contributes to documentation bias. So in conclusion, children with primary neurologic diseases require more critical care resources than children without neurologic diseases. Consistent with other reports, we identified the most common neurologic diseases requiring admission to the PICU and included some previously unconsidered patient populations. The information provided on the prevalence and resource utilization from the study hopefully can be used to inform future research and quality improvement projects. I would like to thank my co-authors, Binod, Tom, Jose, and Peter, in helping support and mentor me through this project, as well as the VPS research staff, particularly Nancy and Gerardo, as well as Margaret Klein, a biostatistician from Children's Hospital of Los Angeles, who helped me in the statistical analysis of this project. And I'm happy to take any questions if anybody has any.
Great, thank you for your presentation. I don't see any questions posted yet, so please, to the audience, if you have any questions, go ahead and type them in the Q&A section. Dr. DeSanti, what prompted you to use the VPS comparative data set for your work?
The major impetus to start looking at the data set was the neurocritical care module. And so that kind of got me into using the data set and trying to work with it to evaluate the utilization of resources among this patient population. And so it was really the neurocritical care module which started my interest in using the data set.
Great, thank you. Also, any challenges that you experienced with your research project?
Yeah, the biggest challenge for me was in the size of the data set which VPS produces was much beyond any size data that I had worked with before. And so learning how to edit and categorize the data was a major challenge for me. And so, for example, we had to recategorize some of the disease processes, which we thought would be categorized as neurocritical care diseases, but do not show up in VPS as neurologic diseases. And so, for example, disease like viral meningoencephalitis is categorized as an infectious disease and subcategorized as a viral disease, whereas clearly that would be a neurocritical care disease process. And so we had to reclassify some of the diseases, which was a major challenge because most of the data sets I looked at can just manually scroll through and evaluate, but the data set was so large, it takes a while to reclassify.
Great, thank you. We have a question from Zach Daniels. From the neurocritical care module, is there any granularity to identify patients with refractory status epilepticus and super refractory status epilepticus?
I do not recall that data being included in the module. I'm not sure. I'm also not sure if I didn't look at if those diagnoses are included in the general VPS database or not. I don't know if you know, Nancy.
Status epilepticus is included, but There's no defining factor for refractory or super refractory.
And also, as far as I remember, the data set does not collect how long EEGs are in place for, but does collect the data for some of the critical care resources, such as central lines and mechanical ventilation.
Yeah, we do collect a one-time EEG and then a continuous monitoring EEG.
But not the duration of those.
Correct. Another question, this one from Gerardo, the VPS statistician. Can the findings of this paper be used to define specific outcomes to do more in-depth research problems in the future?
I think this project might serve as a place for looking at data more specifically for additional projects. And so I think, given that it included all of the data from 2016, I think would require some additional exploration of relevant data in order to do things like potentially improve patient care, contribute to a quality improvement project. And so I'm hopeful that the data can serve as kind of a starting point for additional projects, and potentially serve as impetus to improve patient care.
Great, thank you. Has this research led to any other questions that you wish to explore?
Yeah, one of the projects I'm currently working on is looking at resource allocation by race and ethnicity, and specifically looking at discharge disposition between race and ethnicity. And there's obviously a lot of research coming out that African American, Black patients, and Hispanic Latino patients receive different care than white patients and have different outcomes. And so that's the next project I'm looking on, is evaluating discharge disposition between those patient populations.
Great, thank you. Any other questions from the audience? I think that's it. So we appreciate you joining us today. Thanks, Dr. DeSanti, especially to you for presenting your very interesting work. We look forward to the upcoming February 15th session of the Research Spotlight, and details will follow.
Yeah, thank you so much for having me, Nancy. I've really enjoyed these presentations, and it was an awesome experience being able to give it.
Great. Well, thank you so much. Bye-bye.